Check, check. All right, we're going to start the moderator report back in just a few minutes. If each breakout group should have identified one moderator that is going to come up on stage and give the report back for their group. So we should, I think, have 11. There were 11 breakout groups. So at this time, I would invite one moderator from each breakout, whoever you identified, to come up and join us on stage. We've got the chairs here, and we'll start in just a few minutes. So again, one moderator from each group is going to come forward.
I'm gonna be one of the. You want us to hear? Or? I'm moderating the moderator.
Yeah, hi.
I'm timing everybody. Yes.
How many minutes?
3 minutes each, and there will be a timer on, and there'll be a beep because we have 11 people that are. It's a 45-minute session, so it's gonna be a hard 3 minutes.
Oh, yeah.
Everyone.
Yeah. Yeah, just to clarify, we have moderators from both the in-person groups and the virtual groups that are going to be up here. Virtual participants were engaged. It was exciting. Again, if you're entering the room, we're inviting one moderator from each breakout group to join us on stage. I think we had 11 breakout groups running at that time. So this afternoon we have 13 breakout groups at once. So it'll be a bigger process. All right, while our moderators are joining us, I'll turn the session over to, well, what time we got? We said we would start at 11:45. It's 11:46. All right. So I'll turn it over to our moderators. Dr. Hiroshi and Dr. Hart are going to walk us through the report back, so I'll turn it to them.
Great. Hi. Thanks, everybody, for participating in both the virtual and the in-person groups. We're going to go down the line, and again, we have 11 groups. We have 45 minutes to get to them. We're going to stick to a strict 3-minute cutoff. I will literally say your 3 minutes are up. And so we can start with James. Walk down the line. Just please introduce yourselves and what your role is, and then get going on your report back as to the priorities that you set for what the patient folks.
Will do. All right, start the clock, Rio.
Go.
All right, so James Pittman. We actually Rio and I both moderated one of the virtual groups, and so we were tasked with looking at the questions around from the patient perspective around organ offers, graft survival, transplant, et cetera. And so our top priorities were, again, and a big thank you to all of the participants. They were completely engaged, very vocal, and we used every minute of the allotted time. So we had some really great discussion. So number one was and these aren't in rank order, by the way, but our top 5. And I know we're top 5, so we'll probably hit saturation. Long-term survival and quality of life, right? Know how many patients were referred, how many were listed, how many were declined, and what the intervals were between those periods of those events. What are the contraindications at a transplant program? There was some discussion around the fact that somebody doesn't understand why one program would have a contraindication, but another program wouldn't have that contraindication. And then wouldn't it be helpful if I knew that ahead of time so I wasn't engaged with a program that actually ended up having a contraindication that wouldn't transplant me put me on a waiting list. What are the reasons for graft failure or mortality, and wanting to know specifically what were the reasons at that particular transplant program. And then from our pediatric perspective, what is a typical course for a patient, and educating about the transition of those patients, like for example, back to school into a vocational perspective. So I keep cutting out. I feel like I'm getting my mic cut, but so we looked at what sources of data there are for that, right? And so of course for that the outcomes in long-term survival, there's SRTR and UNET data, but quality of life would be something new, right? So that's data that we don't have. There was a lot of discussion around like a portal, right? And so we said, well, we're not solving the problem here, but that was a really good feedback we felt. For the referrals listed, duration, et cetera, transplant programs track that. It's inconsistent. Some do a good job, some don't. But we don't have that data. So that's something that would have to be invented. On the contraindications, programs have that data, but some of it's nebulous, and we could look at objective data, looking at the things that we'd want. And moving on to Sean.
Needs to not only be written in plain English, but also distributed, and patient education needs to be part of every single one of those things. Okay, Sean, you got 3 minutes. Ready?
Go.
Go.
Good afternoon, everyone. Sean Van Slyke from Sierra Donor Services. So we had a really robust group. Our focus was on what information is important to donor families. Really fortunate that we had Dr. Rolanda Schmidt and David McFarland, both donor parents, and Eric Tavis, who's a liver recipient, that really helped us ground us in our conversations and allowed us to really have some really frank dialogue, so thank you for that. The 4 key items that jumped out to us were a recurring theme, not to lose sight of the human component, that it's important to maintain the dignity of the donation process for the family and for the individual, maintain the respect and the sanctity of the process, that really should be focusing on more so on stories, less so on data, particularly in the acute setting where families are experiencing grief and loss. To focus a better understanding of the timing of the donation process. So how long does the donation process take? What are maybe perhaps some key steps or milestones along the way, and how best to communicate this? A lot of dialogue about customer experience feedback, both for donor families and also for those families that are going through the process that decline donation. I think there's a great opportunity to understand the rationale behind that. It's also important, we thought, to identify where process breakdowns exist so that we as OPO professionals can work to improve that process. And then a recurring theme was also, lastly, what organs can be donated. A lot of discussion about perhaps families declining donation because they don't think their loved one can be a candidate. So everything about age or clinical reasons. And then when an individual is a donor, when organs are not transplanted, gaining an understanding of why those organs are not transplanted and finding a way to communicate that back. I think that's it.
Thanks. Awesome. You can yield your time to our next speaker. Molly?
Molly McCarthy, 3-time kidney recipient, and I'm also already seeing. We actually had, I think, a total of 14 different ideas or points that were kind of on our wish list. We did do our best with Rachel's help to kind of prioritize to the top 2, very similar to yours as well. I think our top 2 really came out to be which centers are most likely to refer, to evaluate, to list, and to transplant a patient like me is how we referred to that. So patients like me being additional types of risk factors. A very close corollary to that as well was how can patients get better information around being listed at multiple centers? There was also a related ask around patients or doctors actually helping and taking a leadership position and kind of walking patients through that process, particularly in the context of where there is multiple centers in one area and a patient with not a ton of travel and travel time associated can potentially be listed in a couple of places. I think the other piece that I would surface too is really around an ask to interpret the data. So not just give us the information, but even so far as to offer some type of a human kind of translator of the data into then, for me as a patient, what does that mean and which parts of those data do I then take to kind of make the best decision for me? Since the hook has not come yet, I will add a couple more that I think were really important to search engine optimization in terms of discoverability. All this is great. I think we've all heard this many times, but how do we actually lead people to it? And how do we dominate the browsers so that the information is delivered right there at the time that we need it, no matter what search is actually put in? And then another one that I was surprised by, but thanks to our team and for the folks who actually contributed this one, up-to-date information about the centers, who to contact, who to reach, who to have the conversation with. So that was a new and unexpected one, and I will yield the floor.
Great, thank you so much. We're gonna go on to Krista.
All right, so thank you very much. I'm very honored to report on living donor information on behalf of my co-moderator, Heather Hunt. We had a really robust group of 15, including living donors, recipients, physicians, surgeons, payers, and regulators. And we were assigned to consider 4 stops on the stubway. I did want to say as an overview that the group endorsed strongly that information collected along the journey should be available at evaluation. And there was a theme of understanding what to expect and communicating both worst case and most common scenarios. So starting with Stop T, the evaluation, the group was interested in complete information on the evaluation process, including how long it takes, navigation support to get through the process, the need for travel versus remote evaluation components, time from evaluation to acceptance decision, and transparent acceptance criteria for donors with my characteristics, as well as acceptance ratios, cost incurred, information on KPD, and tailoring for directed versus non-directed considerations. With regard to the surgery, the group wanted information on procedure types, including minimally invasive, laparoscopic, and robotic, conversion rates to open procedures, aborted procedures, readmission rates, pain management protocols, including use of opioids, and wound complications, cosmesis, symptoms like bloating and numbness. For the early postoperative period, the group was interested in how long it takes to return to normal, early complications, and how to handle, and a big emphasis across the journey on quality of life, patient-reported outcomes, and life restrictions. And finally, in terms of our last stop, long-term outcomes, critical importance of organ failure, failure of the remaining kidney or liver, patient survival, again, emphasis on quality of life, financial implications, all tailored by patient traits. And I will say that the group, patients and donors, advocated very strongly for building up the effort of the Living Donor Collective and really emphasizing how that we can make that easy for patients to participate in that effort. Thank you.
Great, and thanks for the plug for the Living Donor Collective. It's a really important effort by SRTR. Corey, you want to do your report out?
Yes, thank you. So I'm Corey Schaffhausen. I was one of the moderators for the session 1B2, which was the post-transplant portion, starting at organ offers through transplant and outcomes. There was a fair amount of discussion, some overlap that related to best practice for presenting information. And so some of the things that sort of overarching were to have a platform that could provide education to patients and assist with centers that need to do that counseling, so that there's a resource for centers as well as a resource for patients, and that this is something that's available throughout the journey, so that at any stop, the center and the patient can find what's relevant at that point. And then also, because many of these processes are unpredictable and change over time, over long periods of time, that there's a way to kind of come and refresh and maybe take new looks at information as the situation changes. There were a few things that I think rose to the top in terms of specific information. It ranged from specific long-term outcomes to different quality of life aspects. For the quality of life, There was a comment about impacts to pregnancy, the impacts on disability, and the process of potentially returning to work or transitioning off of disability, mental health, and then for pediatric patients, the transition to adult care. For long-term outcomes, there were a few different ways to consider that. One was the potential of the organ, so just the best case scenario for a particular organ, and then also what the actual predicted outcome might be, and it was really key in this discussion that some of the data be personalized to the specific patient characteristics and potentially donor characteristics if that's possible. And then there was some attention to, in a more broader sense of post-transplant education and outcomes, and some of the comments that came up were for the post-transplant journey, understanding more about the potential and the process for rejection and what data is available and how that might happen, the hospitalization and length of stay, the potential amount of time before returning to work, and then again, different types of specific procedures, whether that be for liver, a split liver, for other organs, robotic assist, something like that. All right, I'll stop there.
Okay, thanks. I know I'm being a little draconian, but I think I hand it off to Alex, and I'll still keep on timing people, but I think those are great things. One additional thing I'll take the liberty of mentioning that James didn't is different medication regimens, immunosuppressive medications of different patients at the same center at different centers was a piece of information that patients wanted. But go ahead.
Good morning, Grace Leiden, SRTR. I had the pleasure of moderating a really wonderful conversation with Dr. Hart here with living donors and deceased donor family, and we identified different priorities for those two groups. So starting with the living donors, there was a lot of enthusiasm for the living donor collective. People wanted to know not only what are my risks as a living donor, but what are my unique risks, so for living donors like me, and what are they long term. There was also a lot of questions about finances for the living donor, billing, coverage, time off. Do I get time off? How does billing work? The bills are going to the living donor or are they going to the recipient? And what are programs doing for living donors with socioeconomic barriers to donation? The third priority for living donors was getting at differences between centers, and that was acceptance criteria by center. Where can I go? Where can I not get declined? From the deceased donor family members in our breakout group, we heard that they want more information, more transparency on the allocation process. Obviously, when deceased donor family members are first encountering the transplant system, maybe there's not extensive amounts of time to learn about that themselves, and it would be potentially beneficial to learn about things like longevity matching pretty quickly, because it could be very distressing, someone who's lost a child, to then learn 2 years later that the recipient has died. We heard that in the breakout group as one comment. And so just learning about the matching process, how longevity matching plays in or doesn't play in, and sort of managing some expectations about what can happen after donation, as well as the other big priority from donor family members was what kind of aftercare are OPOs providing. There was a lot of interest in standardizing that, but as far as information, how does it differ between OPOs? And then I'll just echo that everybody did want their information in plain English, but also in Spanish and in languages that are accessible to the many different communities interacting with the transplant system. And please, no acronyms.
I'm also just going to editorialize that Dr. Leiden's specialty is statistical predictions for individuals, individualized risk prediction. So her heart has been super happy this whole conference.
Yeah, everybody's loving what I do today, so it's great.
Go ahead.
Am I next? Great. Hi, everyone. I'm Sean Penny. I'm a transplant cardiologist, and I was joined by David Axelrod. We had a great session, very lively session, going through the early stops on that subway map. So from patients with organ failure through referral to a transplant center, the evaluation and listing process, waitlist management, all the way up to organ acceptance, so stops A through G. So we heard a lot of great ideas from a patient and family perspective. The first one was what are the specific requirements for specific conditions? In other words, with certain comorbidities, am I going to be able to be listed at one center and not at another? If I have a condition, why am I able to be listed at that center and not at my own center? And if I do have a condition, how bad does it have to be to preclude me from being listed? The second thing had to do with distance from transplant centers and how can someone be dual listed? How do you actually do that? So if I live in Seattle, can I be listed in New York? Is that physically possible? And also, if I want to be listed in two centers, is the insurance company going to pay for that? If I have to repeat tests, what tests need to be repeated? Why do they need to be repeated? What information are you interested in finding out? And will the insurance company pay for those additional testing procedures? Next thing was a very concise description of what probably matters most to patients and certain providers, which is what are the outcomes for a particular patient at that particular center with that particular donor, trying to condense it all into one very quick, tight metric that encompasses the patient variability and the patient-driven outcomes, the center-driven outcomes, and the donor-driven outcomes. And then the other thing that generated a lot of comment was who actually gets listed at your particular center. Am I going to find persons like me who get listed at your center? What is the probability of me being listed at that center? And if I am listed, what's the probability of me actually receiving a transplant at your center? And I think those are the main ones.
Go ahead.
Great. So I'm Karen Ledeen, and I'm an ethicist and health services researcher, and I have the privilege of reporting for Group 1B with my co-moderators. So very fruitful and productive conversations. We were asked to focus on offers, transplant, and post-transplant, but I think that the group kind of identified two main decision points. There was a lot of discussion around the decision to undergo transplant versus alternative options and the need for really clarifying to patients the difference in outcomes of transplant versus alternatives. And so there's discussions around better articulating what numbers mean, what does survival mean in that context, and how to promote effective decision making. So whether or not a universal script should be offered with suggested questions, whether a decision aid with tailored predictive modeling should be included, but just like highlighting the very significant need for greater and accessible information for patients, so echoing kind of plain language. The second overarching theme before the specifics was about data versus metrics. So just ensuring that the data that is collected is used to support decision making and doesn't restrict the option set by encouraging cherry picking or defensive practices. So how do we use the data that we have? So with respect to offers, I will say that of the three stations on the subway, offers was of least concern to the group. They did identify that waiting time and individualized prediction of wait times was very important, and listing criteria or bias in listing was also very important. The group was focused on transplant and again deciding how and why to transplant, and then conditional on making a decision to pursue transplant, how to identify transplant centers, again with this individualized conditional outcomes. So can I identify a center where I would do best, or how can I compare a center A versus B? In terms of center-specific outcomes, there was a discussion about short-term outcomes versus pooling long-term outcomes, where the center choice is more important for short-term outcomes, and the patient characteristics may drive longer-term outcomes. And there was also a discussion about the need for tailoring metrics to organ-specific situations as well as pediatric or transitional populations. And in the post-transplant context, there was a lot of discussion about the need for long-term outcomes follow-up and how do metrics play into that or not, specifically quality of life. and half-life conditional outcomes. Sorry, the one metric that was very important that was new was hospital avoidance, so days out of the hospital as a proposed measure. Thank you.
Thank you.
Amin Tabatabai here, a liver recipient. The question that our group looked at was, what do patients want to know? And the room was made up of a majority of quality assurance folks, surgeons, UNOS with 3 patients. We focused on the subway from the organ offer all the way up to post-transplant. And the overarching theme, the North Star, was education, and patients put all 3 of their dots on that one. And part of that is education equals empowerment, right? If we have a foundation of the list and having that not be a black box, it helps us better understand what that looks like, right? And pre versus post. Education is gonna look different at all those different touch points. What does that look like? Is it in person, videos, whatever, right? From there, a close second was regular shared decision making. As patients, we want to be part of the process, so that means understanding the transparency and the acceptance criteria. Why was an organ declined? And some sort of way of receiving updates at a maybe monthly, quarterly, or clinic visit in terms of why certain organs were declined, right? And then from there, we talked about, kind of the organ offer and the longevity info. We want to understand, the organ that we're receiving, how long is it really going to last? Which also tied into taking a look at the SRTR. What would a potential patient-focused report look like that patients could be a part of helping digest and tell that story? So patients would have that report that's almost digested and maybe could be printed out or whatever, but then that report can be taken as part of a convo of having more of like, okay, how does this report relate to me with these certain conditions? Next after that came choices and options and survivability, right? So this ties back to the acceptance now versus like waiting for the next organ. I want to understand what my choices are and what those implications may be on my survivability. Then from there, we wanted to consider and discuss the patient goals over time on the wait list, right? This is a conversation. As my disease or condition progresses, those goals may change, and I'm gonna have completely different goals post-transplant because I'm gonna wake up and I'm gonna feel like a completely different person, right? So how different does that look? And then additionally, understanding that the end, kind of the end stop is that survival rate and the, how well my organ or graft is gonna do. What are the shorter term outcomes, right? And information on, for instance, complication rate, length of stay, return to work, which I think some of the themes have come up as well.
Great, thanks. Jesse Schuld, a researcher from Cleveland Clinic. Had the pleasure of moderating with Dr. Snyder, who we're giving 5 minutes to breathe for once, but our group was very enthusiastic. We had a virtual format. I'm going to try to focus on some of the novel metrics that they discussed in an effort not to get yelled at by Rio. I'm really afraid of him. We did mention the tailored wait time as an important metric, and I think there is information included in the SRTR about general median waiting time, but for patients to be able to enter their own specific characteristics and understand what the expected waiting time would be one that would be very useful. I think somewhat related to what others described, having a patient guide to the SRTR is very embedded. So a way to navigate that. If I'm a patient coming in, what are the questions that I have, and then how that could be linked to the data that support those questions. So how to navigate all of the information, which can be dense at times. One of the other novel metrics that are mentioned was the utilization of paired donation programs at programs and understanding what paired donation is. And this sort of, as discussed, falls in the bucket of you don't know what you don't know. And for a naive patient coming in may not understand the concept of paired donation. So making that very explicit and understanding what the implications of that are, different programs. As mentioned, certainly quality of life was emphasized, and given that there's a lot of prospective data that may be needed to be collected for that in the long term, in the short term, emphasizing things like the perioperative course, length of stay, and really the theme being having the expectations clear to patients going in so they're not surprised on the back end when things might take longer, the complications might be longer than they may have perceived. Having a patient-tailored tool for organ donor offers, as mentioned, and there certainly are tools that the SRTR has created around this, and individualized risk is emphasized, but sort of understanding what the implication is for consenting for higher risk organs, how that would modify individuals' patients' time to transplant, and what the implications would be for next donor offers. The topic of waitlist removal came up, and the information that is currently available is somewhat vague, so having more specific information about why at certain centers patients are removed from the waiting list and understanding if that's applicable, again, feeding the expectations for patients as well. We did have a discussion about offers turned down on their behalf and whether that information and how that should be articulated in a functional manner. I think that's one that's certainly a conversation worth having. Reasons for graft loss was described as well. Again, information going in about what the expectations might be. So I will stop there and really want to thank everyone that participated in our session. We're very enthusiastic.
Nice, bring us home.
Okay, so I'm Sumit Mohan, I'm a nephrologist at Columbia, and the reason you're not yet at lunch. So our group had an equally robust discussion, and I'm going to just hit on the highlights that haven't, a lot of what we talked about has been covered by a lot of the moderators that have talked before, spoken before me. So, the large theme around our discussions was the patient experience in terms of what is the wait list experience, how long, what happens to me, what can I expect, and what's my quality of life post-transplant, and recognizing that patients frequently don't know what they don't know, and so don't necessarily understand what they should ask. So trying to set up a frequently asked questions and a minimum educational material so we don't overwhelm patients to begin with. And then being able to allow those individuals who want more information the ability to drill down, provide data by diagnoses, especially for those rare diagnoses where it may not be statistically meaningful, but for recognizing centers that may do a specific type of surgery, which generally gets clubbed into a broader diagnosis category. There was lots of interest around, trying to understand what's available for patients in terms of support and ancillary services, particularly psychosocial services, which I thought was an interesting aspect of this that we haven't talked about so far. There were questions about insurance issues and how that plays into access and travel. And I think, the question about why this information is not already available in multiple languages and why that's not, that should be kind of a low-hanging fruit we should go after. But I thought the striking point that everybody in the room seemed to agree with was it's important that as we provide this information to patients, that we do this in a manner that allows patients to keep hope. That we don't provide so much information and so much negative information that we take away hope from patients who are looking towards transplant. I'll stop there.
Thank you so much. I really appreciate I think we all appreciate the engagement and the involvement of everybody in the room, and we really wanted to thank you. Something that I'm realizing more and more as each day comes along is that people want metrics, but people want just information as well. And we shouldn't lose sight of the fact that information is out there, but is either inaccessible, not interpretable, or not located in one place. It's hard for people to figure out where this stuff is. And that's something we can improve right away. Part of the feedback we got, for example, from one heart recipients, like, what about information about COVID for us? Where do I learn whether vaccines work for me? What drugs should I be taking if I get COVID? What are my dangers from COVID? I mean, this has dominated our thinking for the last 2.5 years, 3 years, and our patients tell us they don't have the information given to them. We have a website in our transplant center, and nobody in our transplant center says they even know about our website. So we expect patients to pull information. We need to push information. So I think these are needs and feedback we get. The other point that I think needs to be made is that patients don't speak with a monolithic voice. One particular pediatric mom who said, I don't want to hear about the declined offers. I have too much to think about. I'm overwhelmed. Don't tell me about the offers I get at decline. Tell me about what's going to happen to my kid. I trust you guys to not take an organ that's not going to work for me. So I don't actually want to hear about the declines. Some people do. Some people want to hear about the declines. But this particular parent
had no interest in hearing out the clients. We all want transparency. The ASD wants transparency, but some folks, actually, they don't need it. So they may have the option of getting something pushed to them if they choose to want that information. So I think we have to be careful to think about patients with a monolithic voice. They don't. They have diverse interests. They have diverse needs, and so I think we have to be cognizant of that too. We have about 10 minutes for other comments and questions for people that participated in breakout groups and felt that they didn't, their concerns either weren't held or made priorities. One of the priorities, again, from our heart transplant patient, I mentioned this, is that he noticed that he's not on the same immunosuppression as his neighbor is, and he didn't know why. I mean, why do I get this regimen? Why does someone else get another regimen? And why does Center X across the city have a totally different regimen for me? And he had no idea. That's, again, information, not necessarily a metric, but just information that patients thirst for. So any other comments from I know I cut off a few people, so if they didn't get to say what they wanted, here's your chance. And then anyone from the audience who felt that their insight in their work wasn't necessarily prioritized or raised to the level of the highest hanging fruit, lowest hanging fruit.
Hi, I'm Stephanie. My son had a liver transplant almost 4 years ago, and my husband was his live liver donor, so we're a mess. I was just going to say, coming from kind of a different perspective, if the information that people are searching for as a parent or as a patient, if they don't find it through their center or they're not maybe guided to it through their center, then kind of their backup plan ends up being like Facebook, and then sweet baby Jesus, Lord only knows what they're going to find.
Right.
So just kind of thinking that if they want to know, they're going to find something, and once it's maybe not controlled in a bad way, but once it's not accurate information that we know we're giving families, then it's a whole mess on the back end that I would assume as providers you guys of course deal with every day, but I just think that may be a motivation to try to support people as they try to access it.
Thank you for that feedback. We've heard from multiple people, including Heather Hunt on our steering committee, that Facebook groups often are the source of information, and again, the reliability of information is somewhat variable, I would say. So I think if, in fact, one place had a repository of all the different links that actually, SRTR may not collect some of the data, but we could collect some of the places where you can get some of the data, even if SRTR, doesn't actually collect that data. So I think that's great feedback. We need a place for people to go, and that's easy to find, and they may be located in places outside of SRTR. So thanks for that feedback. Dave?
So I thought our group was really well done, and there were a couple of things. One, I'm going to just my good friend, Mr. Knight back there had some comments specifically about sort of utilizing some new technology and AI and that sort of stuff. I mean, obviously we need better data to do that, but the idea of being able to build personas and that sort of stuff so that the people could sort of understand how to navigate through this system in a way that's really patient-friendly and patient-transparent, which I think is a really important and innovative part. It's probably aspirational right now, but we can get there, and we can make smart decisions and help people make smarter decisions. I think the other thing that we haven't heard a lot about is the referring providers needs to be able to advise their patients on what they need and how they need it. And the comment from our colleagues from one of the LDOs was, we all have all kinds of data. If you would just tell us what your criteria are, we'll match patients in the right place at the right time, which is good for transplant programs, so we get people we want and that sort of stuff. So to make that those sort of data available to them in an easily importable form that they can actually utilize their own data systems to use, I think is an opportunity for us again to do that. And whether it's an OPTN requirement that those data and those listing criteria get placed into that, or whether it's an SRTR requirement. But I think both of those points are things we can leverage new technology to drive these referral things faster and easier.
Thanks, David. I do think that it shouldn't be aspirational. We should take advantage of current technology, AI, data conduits, et cetera. And of course, your other points about referring providers, if you look at surveys of who transplant candidates trust transplant nephrologists, transplant physicians versus referring providers about things like what organs that they should accept. And you know, whether we like it or not, we want our patients to trust us, but they actually trust their referring nephrologists who they have a relationship with significantly. So I think it's important to push all the information out, not only to the patients, but all their advocates and their referring providers.
Hi, Valen Kiefer, double organ transplant recipient. There's a couple of things I wanted to say earlier in the session, and I got distracted by emotion because of pediatric parent, and I feel for parents. With being a double organ transplant recipient, I would love to have that kept in mind with data, because that was a challenging thing to navigate, to have a kidney transplant for 16 years and then go into a liver transplant and wonder the dynamics of that and the immunosuppression medicine and worrying if my kidney would do well and all of that. So I just kind of wanted to put that thought out there. And also what you said about COVID really spoke to me, because personally right now I'm in a situation of perplexed on what to do. The only reason why I knew my antibody levels and understood kind of my place as a transplant recipient with COVID is because I'm a part of the Johns Hopkins study, and I learned so much information from that. But other than that, I am receiving different recommendations from a transplant surgeon, from my nephrologist, and I've got a close group of transplant friends, and they've done something different because their doctors have told them something different than mine. And I trust my doctors, but yet they're saying different things, and that's really, really hard for our community. And I don't have a place, been an advocate for 18 years, and I don't have a place to direct recipients to when they ask me questions. You know, I know we're asking a lot of you and we're talking about amazing things, and we have to start somewhere and hopefully someday can get to all of these goals that we have, but it would be amazing for our community to have one place to go for central information. We really, really need that.
Yeah, I think that's a thirst that a lot of folks have. Thank you.
Absolutely. There's something else I wanted to say, and now can I blame it on my transplant medicine?
Sure, you can blame it on us.
Now I can't remember. Oh, now I remember. Prograf, prednisone, I'll blame it on one of them. So we all kind of were, you know how you're a visual learner or you learn differently. I realized the power of our stories the first time I shared mine, and the people that came up afterwards, and the weight that was just taken off their shoulders because they saw someone else that went through what they're going through, or their mom or dad. So when I hear about all of this data, I know that there's some people that will be overwhelmed, or they're in a situation like my parents where they're living at the Ronald McDonald House and their daughter's, you know, predicted to not make it and everything. So I really like this conversation on presenting maybe information in videos or like that. I don't know if that's something in your plans, but I do know that there could be somebody that a support group doesn't speak to them, data doesn't, and it would be really helpful for them to be able to have that visual representation and have that perspective. Personally, I just created a docuseries trying to do that on sharing the trials and triumphs of transplantation to try and help give a resource in a different way. So just that thought of moving forward, of maybe presenting this data in more, you know, just relatable ways to some patients. Thank you.
Awesome. Thank you so much. I just wanted to comment that we did hear that a lot from the focus groups as well, and I was trying to not cause death by PowerPoint, so I didn't include everything, but we got a lot of really great concrete feedback. And Jennifer Jones has also been a big proponent of videos as another method. And also I would just say, you know, related to this human-centered design concept, what we found that the kidney transplant decision aid was created with the input of 60 patients. And so we were able to iteratively change it, run it by more folks, and you could actually see when their brains turned off so that we could make changes. And that's the kind of, I think I'm sure I speak for the other folks at the SRTR, that this is the beginning of the work. It isn't the last time we talk to all of you. It isn't the last time we get your engagement. So thank you so much for that.
Yes, Milton Mitchell. Just to piggyback off the point about the COVID, yeah, I've had 4 shots myself, and I hear that a lot from patients and recipients. You know, I've taken the 1 shot, the 2 shot, the 3 shot, the 4 shot. Yeah. You know, now we're up to possibly 5 shots, and I really would like you guys to consider, you know, some data and follow up, because those questions are overwhelming along with the other questions. Yeah. I even have questions myself. But I take it because I trust my doctors, I trust the team, I trust everybody. So that's my personal, request to you guys. Please look into that. Thank you.
Thank you so much. And that echoes the notion that if you get different advice from all the people you trust, who do you trust more, And it's really a tough decision because these are all experts supposedly, right? And they're telling you, oh, you need this. Oh, no, you should do packs of it. No, you should get the antibodies. No, the antibodies don't work anymore. No, you should get Evusheld, and then, that'll protect you for 6 months or a year. I think it's hard to get on the same page when things are moving so quickly in a field that things change literally month to month or week to week even. But that doesn't excuse us from trying to keep a consistent message from and there are, in fact, options. So they can all be right. So it's a really difficult thing to stay on top of. That's not to say that we shouldn't try to do it, though, and that all of us are responsible for getting that information out in a sort of understandable fashion that doesn't say this is the only way to go. So thanks for that input, and thank you. Oh, yeah, we're going to take one last question. Go ahead.
Okay, so my name's Lorinda Gray Davis, and I am a liver transplant recipient. I received 4 shots, and I've talked about COVID in our peer-to-peer meeting, and we discuss who has antibodies, who doesn't, but we also have to practice what we're supposed to do. Now, my primary care doctor is going to know more about what's good for patients because that's what he deals with. My hepatologist does not deal with COVID because he's dealing with my liver and things like that. And as a patient, I should understand that doctors don't know everything at the same time. They do not. And so when you have a national public policy that we do, we have people in New York, we have people in Virginia, Oklahoma, California, and we put all that information together and we say, okay, this is the most recent information this month on what you should be doing. But talk to your doctors. It's all up to them. But we have to know as patients that, who's really dealing with it. If my jaw hurts, I said this in a meeting, if my jaw hurts, I don't go and call my hepatologist. But as a transplant patient, your first year, you're like, oh man, I don't know, I need to call them. Mm-hmm. And so that's what we need to really, as patients, need to understand, but we also need to know all the information, where it comes from. So,
Thank you so much. Thanks for that input. All right, we're going to close up because we're keeping you from lunch, but thank you so much for your involvement and engagement. We'll continue to talk about good stuff in the afternoon. Thank you.